a lot of professionals feel the great urge to be able to answer the questions. And I think that one of the things that we should be challenged with in our world is, number one, where do we theorize where it doesn't get shared as gospel? I think that's the conversation, is where do we theorize now? Because it can't just be in our little, what we think are obscure journals. We can't just print these things anymore on our Medium, accounts.
Hello, and welcome to Informatics in the Round, the podcast that's designed so people who know nothing about informatics can come to understand everything there is to know. I'm Kevin Johnson, a physician and informatics researcher at the University of Pennsylvania at KB Johnson MD on Twitter.
And I'm Harris Bland, senior project manager in biomedical informatics and PhD candidate in human genetics at Vanderbilt University Medical Center. And you can find me at htbland21 on Twitter.
This episode, we're joined by the wonderful Evan Thornburg. And truly, I mean wonderful. So glad we had a chance to meet Evan. Bioethicist and health equity special advisor for the city of Philadelphia. Evan previously worked in the mayor's office as director of LGBT affairs and just graduated from Temple University here in Philadelphia with their master's in bioethics, where they studied public health policy and the spread of misinformation and disinformation, things we'll talk about quite a bit in this podcast episode.
So I actually found Evan on TikTok.
Yes, you did.
Scrolling through, doing my doom scrolling, but their videos captured me and just sucked me in because their videos were succinct about these really important issues in public health, and they do a great job making it easy for everyone to understand.
Yeah, in a way, Evan totally embodies the values of this podcast. And I was so excited that you gave us a chance to talk. We hope that everybody out there loves what they had to say. So without further ado, let's get into the episode.
Let's do it.
All right. Well, welcome to Informatics in the Round. I'm Kevin Johnson. I guess I'm your MC for the evening. And Harris?
I'm Harris Bland, Senior Project Manager at Vanderbilt University Medical Center.
And we have a special guest, Evan, who you heard about already. Evan?
Hi, my name is Evan. I use she, they pronouns, and I am a bioethicist and work in public health.
Wonderful. Well, we have a lot to talk with you about, but I want to start off by asking you probably a softball question, which is, when you're at home and you're listening to music, what's your favorite genre?
I have a mix of genres that I love to listen to, but it does range with my mood. But I am mostly sort of a R&B, sometimes smoother jazz, a little bit of folk person.
And are you inspired by any particular song or artist in that genre?
This may overdo it for me, but give a lot of who I am away. But I've recently been listening to a lot of Tracy Chapman.
Oh,
yes.
And I want to sing Fast Car, but I'm not going to sing it right here. But I still love that song. Do you know that Luke Combs, who's now made, he has a rendition of it that I have to say, I mean, it's good. I think it's good.
It's good.
I don't know.
Tracy have hers.
I loved that Tracy was clinging so tightly to the rights and wasn't letting people do her music. And I'm sort of like, of all the ones you choose to finally because you know how many people have wanted to cover Fast Car.
Yeah.
Is a million people. And so I was sort of like, why that choice,
Well, this might be a great example of one of the areas that we are hoping to cover today. So Harris, and I think many of the people know that I have taken on a real interest in information, trust, mistrust, trustworthiness, misinformation, disinformation, and how we in informatics can either make that situation worse or better, especially in the world of AI. We were incredibly excited to see the work that you've been doing, Evan, in terms of TikTok. So maybe we could start by hearing a little bit about your journey and how TikTok became one of your outlets.
So weirdly enough, I mean, I've worked in public health through the COVID-19 pandemic. So
Mm,
that's the first like key component to that is seeing how much and I'm in Philadelphia, as Kevin, you are too, and one of the big risks or the big concerns on our end when we were thinking about things like vaccination and encouraging people to get tested and encouraging people to engage in mitigation efforts was misinformation, like because there's so much was flying around. Now, I would initially say that what first was flying around was misinformation because of all the confusion and the fear and like everybody's learning on the fly. What slowly crept in, or not slowly, but sort of overcame that was later on was disinformation. And so I'm watching that in real time in the job that I'm doing in a city that has a lot of the, I hate using the term, but like risk factors, right?
right.
A huge component of folks who are subject to believing or consuming that are people who deal with limited education, institutional education, younger people, older people, communities, vulnerable populations, especially. And poverty has a huge effect on all of those groups, right? And in how they consume information. And so
Right.
Philadelphia has all of those things blended.
Yep.
And so there was a huge risk. And so Philadelphia, what people don't talk about, because we've talked so much about other spaces, large urban spaces and their outbreaks, is that Philadelphia did not experience a similar outbreak to cities of its similar size. And I think that has a lot to do with how, even with our missteps, because there were some terrible things that happened, how well we engaged the population, how much the population did trust us
Right.
and continue to trust us even with mistakes made, and how thoughtful things like vaccine rollout and testing were, and some of the community groups that came together. So that was the first piece.
Mm-hmm.
The second piece was I went to school during the during the pandemic too, because it was so much easier for me to get to and from like work and class, because everything was virtual. And so in doing so, what ended up happening was being in a bioethics course, master's program in a med school. So most of my colleagues in class are M1s and M2s. You also see the effects on, first of all, newer or soon to be doctors' concerns around these issues, because it came up a lot in a lot of our classes.
I'm sure.
And when I started to work on my thesis, so I was like, this obviously has to be my thesis, because the question for any bioethicist is going to be the ethics of these things. How do we design policy? How do we talk about these things? Because even good medical policy can be misconstrued or can be rescinded or can be challenged with the wrong information flying around, like
Right.
the decision upon, there was a large scale meeting of bioethicists around policy relating to vaccination requirements
Mm-hmm.
for transplants.
Yes.
And the reason this happened is because we were seeing a lot of people who were really, really sick, and people who would have been healthy 3 weeks ago now needing things like lung transplants and being so severely sick that they were at the top or the peak point of the list. They kind of jumped to the front of the line, right?
Right.
Mhm.
And then as vaccines started to come out, the question became like, how do we prioritize this if people are refusing vaccination, which is a large scale prevention and mitigation tool?
Right.
Is this something that we should not allow? Is this something that has to be part of policy? And the policy that folks came up with was that it's requisite, because organs are in short supply, which is why they end up going to the people in the worst need and frequently don't even end up in those people's access to those people. And that because COVID is such a large scale threat, we can't risk someone getting sick with COVID and then thus destroying an organ that may have gone to somebody who would have engaged in all the prevention methods.
Oh, yeah. I hadn't thought about that.
And that includes because there was a higher, it wasn't just like people who were not getting vaccinated. Those people were like not saying, I'm not going to get vaccinated, but I'll continue to mask. A lot of them had similar at-risk behaviors. This is the other thing that got thought about, was that if someone's not willing to get vaccinated, they're probably also not masking. There's also these,
Right. Right.
so it puts their organ at great risk. And it means that that organ ostensibly gets wasted if that person gets sick. And the first thing that's going to go is most likely the organ, or the organ's not going to take very well. There's a lot of stuff to it.
So I have to ask you, I'm going to stop you just for a second to ask a couple of questions, just because I think there's at least three terms that are going to turn out to be really important going forward that we should explain. First, what is bioethics?
It's a blend. It's the principles that we design around medicine, healthcare, and public health, basically. But what does that mean? For people who study bioethics, you're kind of studying a mixture of like medical anthropology. There's a little bit of epidemiology in there, depending on which way you go with your elective courses. There is public health classes. And then there's an underpinning of philosophy, helping us understand how we make decisions, right? And so the triangle is that in medicine, there are three core like components, and that is beneficence, non-maleficence, and autonomy. But urban bioethics, which is the specialized program that I was in, expands this further. It's got a more like health equity design to it.
Great.
And so what we end up designing for is we think of these things as justice, agency, and non-maleficence. So there's an expansion or a blowout of like, we can't just do good. We also have to engage in acts of justice. We can't just have somebody be autonomous, but also have agency or be collaborators in their health. If that makes sense.
Makes perfect sense. So just to help, so ethics we think of as sort of the moral principles that govern conduct or behavior. Mm-hmm. And so bioethics would be basically that applied to biomedicine. Is that one way to look at it?
Anything that's health or medicine. Yeah. More and more it's getting expanded beyond just like medical care. It's very, very new in the host of like areas of expertise. It only started in the 1940s.
Yeah.
After the Nuremberg trials. I mean, it's based off of the judge's response to the Nuremberg trials. He put forth like 10 principles or something that he announced when he was giving his final opinion in these trials.
Yeah, so readers who are interested in this, if you look up Nuremberg or if you look up bioethics, you're going to find a ton. There's also information on a couple of the larger government sites about this because it's a really important part of how we conduct research. So if you want to learn about this, look at the conduct of research websites and you'll find it. Let me ask two more terms really quickly. You mentioned misinformation and disinformation. Do you want to describe those two?
Yeah, so there's misinformation. This is just any information that's incorrectly been shared or has been incorrectly been exchanged. It can be to some extent harmless and it can be a mistake. That's what's important to note is so misinformation happens all the time in health. I mean, if you come in and you are a layman, you do not have any health training whatsoever, and you're getting a very severe diagnosis and you hear all of this information from your healthcare provider, and then you try to go home and explain it to your grandmother, who then tries to explain it to your aunt.
The telephone game.
Right. Yeah. It often happens in telephone. It happens in communities all the time. I mean, like, and it's also it's a misunderstanding of certain information too. Like in HIV, when we say that HIV is spread through bodily fluids, a lot of people include saliva because
it's a bodily fluid.
It's a bodily fluid, which is why in HIV we had to start to say, like more specifically, blood and semen and vaginal secretions. We had to be specific in our language because we realized saying bodily fluids was overly assumptive. That created misinformation. But disinformation is intentional. It's engineered, it's created, it's crafted. It usually, for people who are creating it, it has some sort of monetary gain for them to be disingenuous. If it doesn't have a monetary gain, it has a power gain, but that power gain usually is monetary in some way. And then there's a little teeny tiny thing, well, not teeny tiny, but there's a subcategory of disinformation called malinformation. And this is when disinformation is created very specifically to denigrate or create mistrust in a group or a person. So you can have disinformation about a vaccine, or you can have a disinformation about a doctor who's designed the vaccine, and that would actually be considered malinformation because you are trying to tank that person's career, or you're trying to make sure that trolls and other people harass them. The intent of malinformation is to target individuals or a group of individuals, namely vulnerable populations.
Yeah.
I think it's really interesting to hear these terms. And I think that COVID allowed us to have an opportunity to see these things in real time that maybe generations haven't seen and or remember. When I think about historically in America, where we might have seen breakouts of misinformation or even disinformation, I think about the HIV epidemic, but I also think about immigration in the early 1900s,
Wow.
especially around mental health. If you take a look at like Ellis Island and how folks came into the immigration process, anyone that was deemed mentally ill because of disinformation, they weren't accepted into the United States and would be automatically deported. And so I think about, a lot of folks don't realize how prevalent disinformation and misinformation can be in healthcare and health systems, but we have a long history of it. It's just, it has these little waves and it gets forgotten. And then we have another wave.
Well, we've also sort of looked at it in like the historic events of it. We sort of look at it and we almost like laugh at that era or that time.
Yeah.
But with the information that people had access to of that time, it wasn't nonsense. Like, I mean, the very first vaccine suffered from misinformation. I mean, that's the thing that people, and even like, was it John Lister who came up with the surgical procedures for sterilization and for wound care because of infection. I mean, the amount of misinformation, disinformation that was spread about him from medical professionals who thought he was trying to upend them from their surgical residency jobs and their like leadership of surgical hospital spaces. I mean, he was basically like, hey, using these tools over and over again without cleaning them or without washing our hands is causing people to get purple fever. And they were like, there was a lot of information that was spread about him that said he was a liar. I mean, there was huge publications that were put out. And another example would be cowpox and smallpox,
right,
where a really infamous illustrator drew a picture saying that people who got treated for or vaccinated against smallpox with the cowpox virus were going to turn into cows.
Yeah.
Oh gosh.
That's like chicken of the sea, and
tuna.
Yeah.
Or you could turn into Barbie.
My God.
I just saw Barbie this weekend. I gotta say, it's also amazing. Please go see it.
I've seen it. Oh, so good.
Maybe we could have a whole episode on helping Kevin understand Barbie.
Oh, I'm happy to help that. Yeah,
I have never felt more like a cis black male than I did when I was watching that. It's like, I'm sure there's a message here that I'm supposed to get. My sisters were hysterical. They thought it was so funny and so on point. And I'm like, I'm trying, but
it's experiential.
What I hear you saying is you had a guitar that you played for people.
Yeah, you might be hearing that.
There it is. There.
Right. But the point that I think, Evan, the point that you're making about misinformation and disinformation, I want to add one thing to that. I was just at a meeting with the American Board of Internal Medicine, and there was this epiphany that I had, which is, and this isn't just my epiphany, we have a report that just came out about this too, is that today's information may be tomorrow's misinformation, and yesterday's misinformation could be today's information, and that there is this fluid continuum, so that there are people who say things now where the right statement to make to them isn't that what they're saying is wrong, but it is, that was right until this other thing happened, and now we know this other thing. Like people, for example, who still say masks don't help with COVID. And the answer is, well, we thought that until we realized that COVID was aerosolized. And now we know that masks really do help. Some people didn't really get the whole continuum in their statements that they make.
Mm-hmm. Mm-hmm. And I think the interesting thing, discussing this and thinking about who is harmed the most from misinformation are the communities that are marginalized or underserved. And that has been a continuous pattern over time, because information trickles to them and then they might not get the updated information or find an opportunity to learn additional information. And I think about how even in Tennessee, I still hear people continuing to believe that blood type had an effect on your chances of getting COVID. And that was a 2020 theory that was debunked, but there's still people who believe that, who just don't have access to the updated information or have access to people with the updated information. So it's stuck in their memory, and that's what they still think.
So I love that you bring this up, Harris, because one of the things that because you only have so much time and space, and I already had a very long thesis. One of the things that I didn't get a chance to, I think, expand upon as much as I would have liked, and may do it another time, is this conversation for academics and for professionals that we need to have, which is about information saturation, right?
Mm.
Or infodemia or infodemic. That's the other portion of this. The pressure for, in academia especially, the pressure or the interest or the intensity and the reward system that comes with things like publishing has grown at a rate where now every academic, every person who works in these fields, in these worlds, sort of immediately upon theorizing rushes to publish something. And I think
Mm.
that is also harming us. So what you're mentioning is a theory, and it was a theory that was expanded upon in like opinion pieces and in other published works, but it hadn't yet experienced the experimentation or the research that it required, right? Because people were so busy looking for answers. And in this day and age where we have so many forms, I mean, we're sitting here having a conversation on a podcast. There's other podcasts being recorded right now.
Yeah.
There's mainstream media, then there's YouTube University, essentially. There's
Yeah.
all of these places where information and media are being constantly generated. I have a TikTok. Because there's so much generation that's happening, a lot of professionals feel the great urge to be able to answer the questions. And I think that one of the things that we should be challenged with in our world is, number one, where do we theorize where it doesn't get shared as gospel? Because it is very, very important on my TikTok account that I share things that have some finality to them.
Mm.
Otherwise, I risk eroding some trust
Right.
because I've decided to theorize in the public square. And not everybody understands that what I'm doing knows the difference between me as a professional theorizing in front of them and stating information. So I think that's the first thing that really, it's like a more
Yeah.
subtle thing that I haven't really gotten to like expand upon. But it's funny that you mention that, because you're saying someone's theorizing is now still circulating 3 years later in a
Right.
way that has finality to it for people. And they're making health decisions, individualized health behavior and decisions off of that.
Yeah. Yeah, exactly. And what you said about how we publish and then it kind of gets picked up and goes elsewhere is often a nice way to see that misinformation start, because we're seeing that people are looking for published resources in scientific literature, but then CNN picks up this article and puts the CNN spin, which might not be anywhere malicious, but it's just that it changes it into a different format that changes the scientific meaning at times. And then someone on TikTok or YouTube picks it up. And also, it reminds me of, the different versions of the Bible, that there's these different interpretations and there's these different versions that have changed words over time, and it's somewhat changed the meaning. So I think thinking about that, it's interesting to watch that progression and see how the misinformation, like you said, it's not necessarily malicious, but it's that we aren't really giving out finalized information all the time. We're putting out the theories in hopes that it will help others expand that knowledge, but we have the public checking that information out now too and getting very confused.
It's
Yep.
that, right? It's the fact that the public is now hyper vigilant of these things. And what used to be an obscure article that maybe 2 students would pull up in the course of 10 years on
Right.
like JSTOR, where
Yeah.
you like theorized in a process, and the rest of the academic community, niche academic community that you're in, also understood what you were doing, is now subject to the possibility of being public and we just don't know what catches, right? I think that's the conversation, is where
Right.
do we theorize now? Because it can't just be in our little, what we think are obscure journals. We can't just print these things anymore on our Medium, accounts. We sort of have to be a little more, I'm going to use the word conservative, with where we've decided to like do a lot of our educated thinking.
But I have to push back a little bit. One of the challenges of informatics is that it relies on data that are generated by specific subgroups that then can be analyzed. When I hear this challenge of, as you can say, sort of putting theory in the public, I can think of many examples, as can you, about how the face of medicine changed based on somebody appropriately theorizing in the public. You in your role as director of LGBTQ health for the city, which is what you had for a while, right?
I was the deputy director of LGBTQ affairs. So
Affairs.
generally,
Thank you.
yeah.
Yeah. So, HIV. So the stories of HIV, which have been well publicized, began pre-social media. But if they had been happening during the era of Twitter and TikTok and Instagram, etc., there would have been pictures of people with funny rashes that turned out to be cabbages. There would have been conversations among people in New York, California, Florida, who were seeing all of their friends dying of some mysterious illness that nobody was spending any attention on. And there would have been allies and supporters around a theory that the government maybe is ignoring what's happening with these patients who were dying of this disease that had no name, right? So actually, that would have been a good theory to put out in retrospect, and it could have potentially hastened Reagan's decision to fund AIDS research. Another example, there is this group of people in China who seem to be dying of an ARDS-like illness in January. And in the era of social media, it quickly went out that this might be a virus that was early on called the Wuhan virus and had other names, but it was recognized in people in California that they were seeing a similar small population of people who had been coming in from Asia, who also had contacts who were getting, initially just they were getting it, but then later their contacts, an ARDS-like picture. So the theory that this could be a virus and that it may or may not be transmitted from person to person was put out in the public. So wouldn't you say those were great examples, although risky examples, of public theorizing?
So it's not me saying that public theorizing all has to stop. It's more me saying that we have to be decisive. I don't think that sort of public theorizing was bad. I think that was important because people should know that there's a sickness that is occurring for people. But do I think that the person who said, like, well, maybe it's attached to blood type should have theorized in the public square? No. I think we have to look at information and say, and again, this is someone who loves information and loves sharing it, but we have to look at information, especially when we're theorizing it, and recognize when we have a lot more information as academics with training, right? I think that's what's super important. I think, like, for example, VAERS is open source. I don't love that anymore. And the reason I don't love that anymore is because people don't understand VAERS.
What is VAERS? What is VAERS for our audience?
Oh man, what does it stand for?
I think it's the Vaccine Event Reporting System.
Yeah, yes. But but the A is like
adverse.
Adverse, yeah.
Right. So the vaccine, so VAERS is the Vaccine Adverse Event Reporting System, I think.
Right. And the issue with this is that it's open view. Anybody who has what they think is related to their vaccination and reported something is in there. So if I had a vaccine, if I received a vaccination and then stubbed my toe, I could say, oh, the vaccine made me clumsier. And it's just like, those things are unrelated events. A lot of it that's in there is just generally somebody reporting something that happened to them in conjunction or relationship to when they had a vaccine. It's all hypothetical. But a lot of the general populace doesn't understand that. They think that it is, okay, these things are listed here, so these things are related to vaccination. Yeah. And so I think that there's two ways to answer that. There's multiple ways to answer
Yeah.
this, is that either we have to really get better at and younger with educating people about how to consume theory.
Yep.
And or, because things can be a yes and, we have to start to become more decisive of what we theorize on in public square. If there's a sickness going around, I think it's important people to know that they're at risk. But if we're all starting to get into the weeds of what could it be attached to, we should be careful. We should be careful, because that ultimately people will again take that to be the gospel. Us three sitting here and saying, well, maybe it's attached to blood type, maybe it's attached to sickle cell anemia, maybe it's attached to, is good theorizing amidst people with information and education and the scientific background. It's not always good when everybody of any background without the primer information can participate, or can walk in on the conversation for 10 minutes and walk away and start to share that, right? It's sort of like and it's not me wanting to be secretive. It's like it's difficult. I would prefer that where we landed with this is that we became more educational.
Yeah, I think your point is right on, in that one of the things I really love about this is recognizing that in a world where citizen science and transparency and where do your tax dollars go is one of the expectations these days, we are also sowing the seeds for people who don't understand the continuum of care from theory to fact, or at least today's fact. And as I'm looking at the VAERS system on screen right now, it's occurring to me that, wouldn't it be great, for example, if we had some tools, maybe they're AI based, whose job is to provide metadata so that anyone looking at it would actually see something like, in the entire internet, this is the first such report, or this has been corroborated by 1,000 other entries, or just some sort of evidentiary base that says you should pay attention to this, or it's a little early to pay attention to this. Because your point about blood type, when that first surfaced, there were many people who were trying to figure out the so-called long COVID. And there continue to be researchers looking at all sorts of issues related to HLA, which is basically sort of like blood type, right? And other ways in which we can understand these patients. So it's not a wrong statement, but what it is it's an early theory. And helping people to get the idea that you may see things that we will call not quite ready for prime time on the internet versus other things that are asserted as ready for prime time, but are actually either wrong now, or used to be right, but are no longer right, or that are conjectures, versus other things that are absolutely targeting you as a person who's into, you're almost a flat earther, so you're going to believe anything we tell you, and you need to basically pay attention. So do you, given your, really excellent points here, what are you doing in TikTok to help people understand this issue of information, misinformation theory?
Well, one of the things I like to do is I like to simplify information. I think when we had a section on health literacy, and simultaneously I was exploring a health literacy project at work, one of the things that really was jarring for me to learn was how much disparity existed between people's actual reading comprehension levels on average.
Yes.
And that's just reading comprehension. Like health literacy is even lower than somebody's reading comprehension. So reading comprehension is just like, can you read street signs? Can you read the newspaper? Can you read a book? Health literacy and the very specific terminology and language and background that is needed for health information is even lower on average for people. Again, and I don't know if this is ego or hubris or what, but it's super important in my mind that we make these things accessible.
Yeah.
And it's possible. We don't have to call, my favorite example is we don't have to call everything, gastroenteritis. We don't have to do that. We can say you have a stomach ache. We can say that.
Yeah.
And that is by and large correct, right? I understand for people, who work in the sciences to be like, well, it's not exactly a stomach ache. Like, okay, that's for us though. Like, I got it, like I got it. But do you think that if you point out those like splitting hair details that the science needs to know to someone whose stomach is hurting, do you think they want you to be talking about their stomach ache?
Right.
That's what they're feeling. I understand the stomach's a complex place. Okay. Like,
Yeah.
I understand that. Somebody else doesn't understand that. Their
Yeah.
stomach hurts. So recognizing when we need a fine pen and when we need a wide brush is kind of what I want people. So I hope that people who work in medicine and follow me get a sense of that and realize like, oh, this can be simplified. I actually had a neuroscientist who teaches a class on polypharmacy, which is just the issue of people taking multiple medications together.
Right.
I did a 3-minute video on polypharmacy, and he dropped into the comments and he said, this is a really great video. I only have one really important comment. And he followed it up by saying, you did a better job of explaining this in 3 minutes. That is so comprehensive than I have ever done in my class.
Wow.
Wow.
And he was like, he's like, I have struggled to communicate this to students. And I am baffled that somehow you like picked out the parts that really need to be known for other people to be encouraged to look at their like grandparents' medication cabinet and like ask questions. And it's that, right? That's what I hope to do for people who are professionals or who are scientists or have these backgrounds. The other thing I want, hopefully in some of my videos, is for people to learn that not everything is this or that, right? We have very dichotomous minds, and the internet has not made that better. And I think what I love about being a bioethicist, and the reason why I'm not like an MD or like any of the things I aspired to in medicine prior to becoming a bioethicist, is that I love the human component. The very first class you have in bioethics, at least with the teacher I had, the first thing she said was, you are going to be sitting in this class and hoping that I'm going to teach you how to make the right decision amongst a bunch of wrong ones. And she was like, it's not going to happen. More often than not, you are going to have to make a decision between a bad thing and a worse thing, or a not so great thing and a terrible thing. Not everything, and sometimes you're going to just have like, or you're going to be in a space where you're going to have to communicate that something is neutral, even though everybody wants it to be bad. And that's hard.
Yep.
That's harder than finding the good or the bad in things. Not everything has a good and a bad. Some things just are. Some things could be worse.
Right.
And I think that's what I hope for people to understand. I see it a lot in my comment sections when I pose a question on one of my videos, that people try to answer the question.
Right.
And they try to answer it with finality. Like, well, this has to be like the one that's got the worst amount of this is the question I ask about the religious rights of someone being fed lab-grown meat against their knowledge, against their consent, which is a real threat. And a lot of people in the comments they're like, well, it's not halal because of this, or it's not kosher because of this, or like, and then other people are like, well, it is kosher because of this, or it is halal because of this. And I'm like, see, like, and none of you are wrong as far as we understand halal and kosher. And that also wasn't my question. It was about the rights of the individual. But people really want their answer to be right. And I think I want people to better understand that in the sciences, I think the further along you get into the sciences, the more you realize that you're striving for the right answer, but there's so much gray space around.
Yep. This is a terrible analogy. I'm still going to make it. I really enjoy the series called The Good Place.
Oh, yeah.
And in this season, one of the kind of recurring ethical dilemmas was you're on a trolley and the brakes don't work and you're headed for this entire crowd of people you don't know, and you can either hit them or you can veer off to the other track where this person who you know very well is sitting with his or her child. What do you do? So do you hit the strangers that you don't know? Do you hit and your point is that's not the type of decision most of us have to make, right? But many people think that that's the decision they have to make. And so they emphatically defend what is an impossible, essentially a no-win situation. And I think that has major data implications, right? Because the data can only sort of tell us those things that are in the data. The data may be biased, and we know that. The mechanisms we use to assess truth in data, typically statistics, may be biased. We know that too.
How it's read may be biased. Like
correct.
The data may be well presented, like well published, but how it's read by any number of individuals can be biased.
That's right. That's right. And then you add AI to this, which can produce very authentic looking material that
but
may
has
or may
no
not
ethical
be.
principles.
Right.
Yeah.
I love the trolley car example because there are people who bring that up, and
So I'm not the only one who watches The Good Place.
Oh, I love The Good Place.
Well, the trolley car example, it comes up in bioethics, but what we end up doing is that you ask the question, on one side you have, 3 children tied to a track, and on the other side you have a murderer. How do you swap the tracks? And this is the reason we do this exercise in this way, to understand it, is to understand how our morality shifts or becomes a struggle as we learn more about the ordeal,
right,
or the instance or the example. And that's why it's important that we aren't this dichotomous, because we recognize that our morality can shift. So in that first one, everybody's answer is, oh, for sure, you hit the murderer. If we have to sacrifice somebody, it's going to be the murderer. Then the question becomes, okay, we find out that the murderer is also a child.
And
then everybody's like,
no fair.
Yeah.
Right. Then people become up, they're like, what, and that becomes more difficult, right? Because now you felt your morality. And so the question that, the professor then asked was like, why did you hesitate? You were so certain. Nothing changed about what you knew the first time. We just added more information. Why are you hesitating now? You were very certain before. So then the next layer is, it's not just any child, it's your child. Your child's a murderer. And there's innocent children on this side. And then you can see how morality can be biased, right? Because morality can shift based on more details, but then when you add in your own experience, it can be more biased. And that's important to know about ourselves. So the trolley car, when people bring it up, the sad thing is that they don't complete the exercise, which is, it's supposed to do that.
Got it.
Yeah. It's interesting because I see that intersection of morality and bias being a way to cultivate the misinformation as well. I'm here in Tennessee where we've had a lot of discussions about LGBT health, particularly gender-affirming care and the abortion care with Dobbs. And it's driven often by bias, either side of the spectrum, but that's also a bias from people's moral stance on those issues. And I've watched how misinformation has gotten intertwined into them on both sides of the discussion, and trying to get people to understand that healthcare, we have seen it as very binary, finite. This is, if you have a stomach ache, you take a pill, or if you break a bone, you put a cast on it, or if you have a heart attack, you have a surgery, or, we all have, if you have this, then you do this. And I think that when you add this morality component and maybe even pushing it into a misinformation component, it really creates a situation where people, like you said, you don't have a good decision, bad decision. It's a bad decision or worse decision. And a lot of people don't like to have that interaction at all, ever.
Right. It's when morality is based inside of ideology. Ideology requires us to simplify all. There's no nuance to ideology. And when I say ideology, I say that for any form, right? On all sides. I mean, we've made these things on a spectrum of like conservative and progressive, but I know plenty of people who are hyper progressive, who some of their ideology, I'm like, you still should challenge that. Like you should
It can be a full circle.
Like there was a really great video from another account that I really love, and one of the things in their video, they talked about like people asking, well, why don't we just kill all bigots? And my question became, how do we define bigot?
Yeah.
And as we define bigot, are there any instances where someone can fit the definition of bigot, but it may not be, when we learn more about their scenario, would we feel comfortable still following through with this finite decision to kill all bigots? And people started to be like, well, and I was like, you can't, it's hard.
Yep.
And people who their ideology says that abortion is wrong have not been taught about how abortion is cancer care. And that makes them very uncomfortable when they learn that one of the things that has to happen in cancer care, unfortunately, that a lot of people discover their cancer while pregnant. And in order to care for their cancer and ensure the survival of someone who is most likely already a parent, most likely the cancer will render it impossible for both the fetus and the birthing person to survive. People get really uncomfortable then with their ideology, because their ideology didn't tell them that abortion is care for cancer. Their ideology told them that it's just women exclusively who are making all the wrong sexual choices and who are optioning this as their form of like addressing their bad moral decisions, right? We want to, and we should also unpack why we want to punish women for being sexually explorative, but like that's a whole other conversation. But if we're just talking about medicine,
yeah,
you have endangered someone's mother who is discovered cancer while 3 months pregnant. What do you do? Do you refuse her the abortion? And it's also why a lot of the anti-abortion movement has started to try to like pull the hairs apart on how they're like, oh, when we said abortion, we didn't mean that. That's a DNC. They've started to try and like embellish what they meant. And it's not what they meant. And so it's very interesting but ideology, I think, is the real struggle. And I have plenty of ideologies that have finality that I love to work on, or I want to work on for myself as a person. But as a bioethicist, I have to be this conscientious, at least be conscientious of that and how that affects decision making, and that it's not so simple. And that's why I think I love putting people through these thought experiments, but I wish we would do it younger. I wish we would show this kind of detail in the world when we're younger. I was very blessed to get philosophy courses in high school, and so I sort of had an initiation to it, but we never move away from that elementary design of like there's big and small, there's short and tall, there's blue and red, it's too, we don't blow it out for people.
I think a part of the strategy might be to help educate younger generations about the next question one should ask. Right. I think that it's very easy for us to have a very closed-minded approach, if you will, a dogmatic approach to many decisions. A really good example, there's another person in Philadelphia who just moved here from Columbia, who's now an Obama Foundation scholar, Desmond Upton Patton, who at some point we'll get on here. But Desmond's work is incredibly enlightening. He's using AI techniques, and he's got a group called the Safe Lab. They're using AI techniques to take the tweets of people who come from communities where we typically have strong biases against that community, to your point about the murderer who's a child, right? And using AI to basically translate what's actually happening in this person's life so that other people can appreciate who they are as people. And as a social scientist, social worker, which he's already always calls himself, this work has just been eye-opening. And that's partly why I think President Obama wanted to get him into this group. And his whole point is the people who are making these decisions, is exactly the point that you're making, Evan, maybe see these people in one light, but they really don't see them as humans. And in fact, it benefits them, the person who is making the decision, not to think of them as humans and to have something they can say, thinking very much sort of like, the George Floyd type, or many of the people who've been subjected to police brutality in the last 20 years. It's better to be able to say there's something about them that makes them deplorable. And therefore, although this might have been a wrong thing, this was a person who deserved to have the wrong thing done to them, versus unpacking that. And his work unpacks that and says, this person who maybe did something that made her get killed, and he's writing a whole book about this, watched 3 of her friends get needlessly killed in school. And her tweet story clearly tells about that trauma, but it's written in street language, which means nobody takes the time to sort of unpack what is meant by these phrases by this person. So I think one of the things I'm hearing you say, and I'd be curious if I've got this right and if you have other suggestions, is wouldn't it be great if we had the ability to either expose the question that other people are not asking but should? In other words, what is there about this person we need to know? Or what is there about this statement that maybe needs to be placed in context? Or if we could educate other groups of people about the way to process information so that they don't fall into these heuristic approaches or biased approaches. Is that what you would say are some of the key take-homes?
Yeah, I mean, for sure. I think that, and we can't know everything about everyone in every scenario all the
Right.
time, but I think just being able to get comfortable with the question.
Yeah.
And not just the question of like, not the confirmation bias questions. I think we're all comfortable with that, right? Like, well, what did they do that got them killed? The reason we ask those questions is because of anxiety, and we want to know that we're doing everything we can to be safe, right? So if we say, well, every time someone's killed by a police officer, they did something, they said something, they were antagonistic, they were erratic, we try to name all of these things that we think we would never do if encountering a police officer. That makes us feel safe. It makes us feel in control of being of that's one way we will never die, because we would never act erratic. We would never pull a bag of Skittles out really fast. We would never, like, we have this belief about ourselves that if we can ascribe some form of blame, it'll never be us. I think it's also, I think for very privileged individuals too, to say that about an experience they have never had. I think what's very interesting, right, is that even in this podcast, right, when we veered off for a second to talk about Barbie did not make sense to you or didn't read to you. And I think for me and Harris, Barbie reads to us because Barbie is an allegory for things that we've experienced. But I think for a lot of cis men, especially cis het men, who went to see Barbie, their response has been like, this hates men. And that still is a really good takeaway as like an emotional response, because that's what Barbie is saying. Barbie's like, yes. And when women or these types of folks go and see a movie, that's frequently what we see, is that this movie hates us. Or it's simplified us down to like patriarchy and horses. Like we feel that simplified. And for some people who walk away and say like, oh, Barbie hates men, my answer is like, did you see the end? Because Barbie challenged Ken to be more. That the patriarchy doesn't just hurt Barbie, it also made Ken overly simple, and he could be complex too, if he wanted to. But I think that's what happens for a lot of folks, especially folks from a privileged standpoint. And so it's easy to blame an individual for what has occurred to them, especially an individual in an experience that they'll never have, right? It's easy to blame somebody with mental health challenges and disorders for why they were killed by the police.
And you hit this key point a second ago about safety. And I think one of the things that we saw in COVID, and we see, I don't even think it's just social media that created it, but I think we see it more in social media just because of the access to seeing it, is that people make very quick decisions on what they believe because they want to feel safe in their decision. And they want to feel safe in general. And so they just go ahead and make a confirmation bias, or they go ahead and make a decision based off of the information so that they have a binary decision on where they've gone. I believe this or I believe that. And then they can settle it and they don't really have to think about it anymore. We don't, as a society, really want to take a pause to consider all the different variables because that would take time from having to go to the next thing. And we see it a lot in healthcare. Let's go ahead and make this decision, see if this treatment works. Let's look at this data set. Does it confirm what we already think? We see it often in treatment plans. We see it in healthcare in general, and so I think it's easy just to make that decision and move forward and not always consider other variables. We see that especially in healthcare data with social determinants of health. They aren't captured very well, but sometimes those are the most rich data to be able to understand why someone's health is the way it is. If we understood their air quality or smoking status or the fact that they were unhoused for 15 years and these variables that we haven't caught in the health record for a very long time, all of a sudden are now becoming more important because we see how much they've affected people's healthcare for generations.
Right. And like what you're saying is that like a lot of what we experience in healthcare with people's beliefs and their behaviors can be explained with anxiety and fear and misinformation and disinformation. One of the things that really came through, and I had to read so much research from across the spectrum. I had to leave healthcare entirely if I wanted to do this thesis. I had to look at like Homeland Security reports. I had to look at a lot of like media research. I mean, there was a lot that I had to consume to put together the theory that I present. And the thing that boils to the top ultimately is several key points, which is people are anxious, people are afraid, and people are alone. And those are just such key components for why people even seek out or become invested in, especially conspiracy theories, especially people going all the way to that far end of consuming misinformation, disinformation to the point where it becomes ideology.
Right.
COVID really shows us that. The walk away that is that people who intently bought all the PPE and still are doing an extensive amount of like hand washing and all the things, that we told people to do in the beginning, those people are experiencing anxiety and want to control the threat to their health and their fear of death and dying or their fear of getting sick. But the people who said it's not real, the people who said they're not going to mask, the people who have said that the vaccine has, nanoparticles in it, those people are having a similar emotional foundation.
Yeah.
Their decision was to deny this thing because that felt like they could control more. If this thing doesn't exist or if this thing is being overhyped, these are the various ways that people deal with anxiety and feeling out of control and feeling afraid and being alone and having no real strong resource in their community to trust with like backing this information up.
Oh, I have to say, this has been an incredibly enlightening hour. I think we need to close. And I guess to do that, and obviously, Evan, part of this is this inviting you back because we're going to have to continue this conversation. There's no question. And I hope, maybe we can also get on your TikToks and podcasts and blogs, et cetera, too. I guess in closing, what I would ask is if we could leave the audience with a message about how they can get from misinformation to decision making, what would you say they should do?
I think it's about first finding trusted and informed and educated folks, and that can be someone in your life, but also being comfortable with a soft amount of challenging what you learn and also looking at the resourcing. I always encourage people to get more adept at looking at what's the resource. And the other question I ask people to look at when it comes to especially disinformation is this somehow going to result in this person being able to monetize? And frequently that is the key in there. When people share disinformation, especially at the heights, ultimately they're always trying to drive you to like buy a supplement from them or to, for $49 a month, you can be on their VIP list on their website and have access to all their special lectures. And there's all different ways that they figure out a way to monetize. But when you start to see monetization pop up in a way that is uniquely for them, and that a lot of disinformation creators, it's a closed loop.
Right.
They re-reference each other. So one of the things that And I encourage people to be interactive. That's why I think TikTok's such a great platform, is that people have frequently asked me on my videos, like, well, what's your source for this? And I list it. I don't care if it takes me 7 comments. I will list all of my sourcing because I do want you to do that. I want you to even challenge me as an educator on this platform. I want you to say, well, where did you get this from? I like to post book lists for that same reason, because I want people to say, like, well, where can I learn more? Another thing that people ask is like, well, this was an interesting video, but where can I learn more? I'll give you 6 books. I want you to explore your world in that way. And I frequently try to give people reading material that is designed or written for anyone for any number of people without health training to read it and understand it. That's what I want you to do. So ask for referencing, ask for resources, ask for where you can learn more about this thing. And then when you receive them, if you receive them, also look at where that resourcing comes from. Is that article that's written, all the resource material comes from the same author? Because I've seen that a lot.
Yep.
I've seen that a lot.
Yep.
Or the same 3 authors that are using each other's same papers as proof or as referencing. Ask more questions.
Yeah, I mean, this is brilliant. I think it's another play on don't judge a book by its cover. Open the book, right?
Yeah.
And in this case, look for references, look for supporting information. Super helpful. Harris, any final words?
This is fantastic. I think, listening to this conversation and being a part of it has made me remember that we do have to be careful with having really in-depth conversations in public audiences. And being a scientist and being in healthcare, we can consider how those words can be magnified through social media. And so adding context is really important. And I think it's also, what you say on TikTok, and I've enjoyed your content so much, being a part of those conversations, engaging people, let them know that you can be a resource and saying, like, please challenge me. They need folks like us and conversations like this to happen so that people can start to think a little bit more broadly about their beliefs and their thoughts around these topics and challenge themselves.
This is great. So thank you so much. This has been really fantastic, Evan. And will you come back if invited?
Sure, absolutely.
Sometimes Kevin will often offer limoncello, and that's always a good time.
All we have to do is get everybody together. But what I can offer is that I know exactly the music to play now. So you'll hear it later on. But this has been great. Thank you so much.
Thank you. Yeah. All right. It was great meeting you.
So I definitely agree with Evan that in medicine, we have a tendency to believe in these dichotomies, either good or bad. It's often very binary.
Yep.
Often, I think good information is nuanced, and so it can be either twisted mistakenly or purposefully.
Right. I mean, I was so impressed by Evan's open-mindedness and grace, just acknowledging that we all bring our own biases and ideology to assessing information we see in the media. And Evan and the TikToks really described that well, too.
Yeah, even better, Evan provided us with these practical ways to assess the validity of information that we see online. And I think that can be really useful to everyone, a medical professional, or even just the casual TikToker who's scrolling through. So I'm so glad they decided to join us.
Definitely. And I think it makes total sense to end with one of their favorites, Fast Car by Tracy Chapman.
Yeah.
The reason why I think it makes sense is that I will bet you that many people who have heard and, quote, memorized lyrics from Fast Car have no idea what it's actually saying. I think it kind of in some ways embodies the way in which misinformation circulates.
Yeah.
And, I didn't talk about that with Evan, but I will, because I made a point of re-examining the words, that Tracy Chapman and now Luke Combs have produced. And I never found it to be a song that was totally depressing. So I myself kind of had this epiphany of, stuck in the same pattern as her dad and mom. Yeah, okay, I get it now. So I think it'll be a great song for people to hear again. Anyway, thanks for listening to the episode. To hear about new releases, please look for us and find us on social media at InfoInTheRND on Twitter, on Instagram, on Threads, and on TikTok.
And if you have any questions or ideas for the things you want to hear about for new episodes, message us on any of these platforms or email us at informaticsintheround@gmail.com. And if you would like to hear more from Evan, you can search them on TikTok at EVN, the bioethicist, or Gay G-Town Bay.
See you later.
Goodbye.